Hi everybody, and welcome to our module on metabolic alkalosis. In the video on acid-base principles, I talked about the 4 types of acid-base disorders, and in this video we're going to focus on the third one, metabolic alkalosis. By way of review, in a metabolic alkalosis, the serum pH is greater than 7.42. The normal range for pH is 737 to 742, so in an alkalosis the pH is too high, and in addition the serum bicarbonate level is high. If you look at the Henderson-Hasselbalch equation at the bottom of the screen here, in a metabolic alkalosis you have an increase in bicarbonate. That's the primary abnormality. Because bicarbonate is in the numerator of the Henderson-Hasselbalch equation, that will lead to an increased serum pH, in other words to an alkalosis. And then as a compensatory response, the carbon dioxide level will increase. This is the result of respiratory compensation. On this slide I've written the 6 major causes of metabolic alkalosis. We'll go through them one at a time. The major causes you'll see clinically are gastrointestinal acid loss and contraction alkalosis. We'll also talk about all these other things in this slide here. Secretions from the stomach, as you may know, are acidic, so when patients lose stomach secretions, they will lose gastrointestinal acid. And this occurs in patients who are vomiting or in patients who are placed on gastric suction. Because parietal cells secrete HCl, when gastrointestinal acid is lost, the patient will lose acid and develop an alkalosis. In addition, they will also lose chloride because there's chloride in HCl and develop hypochloremia. Hypochloremia is a classic feature of the alkalosis that develops when patients have GI acid losses. These patients also will develop hypokalemia. There is some potassium in stomach contents. And in addition, patients who are vomiting or have gastric suction lose intravascular volume. This activates the renin-angiotensin-aldosterone system, and aldosterone causes potassium to be excreted in the urine. So the net result is that patients who have gastrointestinal loss have what's known as hypochloremic, hypokalemic metabolic alkalosis. And make sure all these terms make sense to you. This is the basis of lots of questions on step 1 about whether certain values in the serum go up or down in the setting of GI acid loss. The second major cause of metabolic alkalosis is hypokalemia. To understand this, you need to appreciate that potassium and acid can exchange with one another to go in and out of cells. So when you have hypokalemia, if you look at the cell I've drawn on the screen here, the potassium level becomes low in the serum. That tends to draw potassium out of cells in an attempt to replace the lost potassium. In exchange, hydrogen atoms go into cells, and that causes the pH to rise, and that leads to an alkalosis. The reverse of this can also occur if you have an alkalosis for whatever reason that can cause hypokalemia. Next major cause of metabolic alkalosis is called a contraction alkalosis. It gets this name because this occurs whenever the vascular volume in the body is contracted or decreased. So if a person loses fluid with sodium and chloride in it for any reason, this could be due to hemorrhage, this could be due to vomiting, this could be due to polyuria. If any of these things happen, the effective circulating volume in the body decreases. This activates the RAS. It also activates the sympathetic nervous system. Well, when these systems are activated, more bicarbonate is absorbed in the proximal tubule. In addition, aldosterone promotes proton secretion in the collecting duct. So what you get is a net resorption of bicarb and secretion of acid in the urine, and that leads to an alkalosis anytime volume has contracted. Here's a slide from our nephron physiology module just to remind you of how sodium and bicarbonate reabsorption are linked in the proximal tubule. The proximal tubule reabsorbs sodium from the urine and then pumps it out the other side of the cell together with bicarbonate. And this entire process can be increased by the sympathetic nervous system. So anytime there's a fall in the effective circulating volume and the sympathetic nervous system activity increases, there will be more sodium reabsorption and also more bicarbonate reabsorption. And because of the bicarbonate reabsorption, any fall in ECV can lead to a contraction alkalosis. And here's another slide from our nephron physiology module just to remind you of what aldosterone does in the cells of the collecting duct. So aldosterone can promote sodium reabsorption. It can also promote potassium excretion, and aldosterone also drives acid excretion. So what this means is that when the RAS is activated from low ECV, there's more sodium reabsorption, more potassium excretion, and also more acid excretion. And that's why contraction of intracellular volume, which activates the RAS, can lead to an alkalosis. There are many causes of contraction alkalosis that you'll see in clinical practice. Vomiting can cause a contraction alkalosis, and as I told you before, there are also gastric acid losses. So for both of these reasons, vomiting leads to an alkalosis. Diuretics cause the volume to contract, and that can cause an alkalosis. Diuretics also often cause hypokalemia, which further contributes to alkalosis. Heart failure is associated with low effective circulating volume, so is cirrhosis. In addition, both of these disorders are treated with diuretics, so because of the fall in effective circulating volume, plus the use of diuretics, patients with heart failure and cirrhosis commonly develop a contraction alkalosis. And I'll just make one final point. There are new data that suggest the real reason for a contraction alkalosis is not the loss of volume, it's the loss of chloride. When you lose volume, you lose sodium chloride, and there have been some elegant experiments that have shown chloride repletion is what's necessary to resolve the alkalosis. They're not going to ask you about this on step 1, but I'm just mentioning it because you may read about it in your textbooks. Diuretics are another classic cause of contraction alkalosis. Specifically, loop and thiazide diuretics are the drugs famous for causing a contraction alkalosis. They do this through a couple of mechanisms. First of all, these drugs increase sodium delivery to the distal tubule, to the distal part of the nephron here. And anytime you have more sodium flowing through this portion of the nephron, you will get more potassium excretion, and you will also get more acid excretion. Sodium and potassium and acid excretion are linked in this manner. So patients on these diuretics, as you know, develop hypokalemia, but they can also develop a contraction alkalosis from the sodium effect. And then second, as I told you before, diuretics cause volume contraction, and this can lead to more aldosterone effects and a contraction alkalosis. Hyperaldosteronism for any reason can cause a metabolic alkalosis. This includes primary aldosteronism. So primary aldosteronism occurs in patients who have adrenal hyperplasia. It can also occur in patients with an adrenal adenoma. This is called Conn syndrome. In both of these situations, there's overproduction of aldosterone. This increases the secretion of acid, causing a metabolic alkalosis. It also causes hypokalemia. And then finally, anytime aldosterone activity is excessive, the body is going to hold on to more sodium, and this is going to cause hypertension. So in a patient who has a metabolic alkalosis plus hypertension plus hypokalemia, that's when you should think about hyperaldosteronism. The milk-alkali syndrome is the triad of hypercalcemia, metabolic alkalosis, and renal failure. This is what occurs in patients who take in too much calcium and too much alkali, meaning too much of a base. This usually occurs in patients who are taking lots of calcium carbonate together with milk. Calcium carbonate is a base, it is alkaline, and when you take it together with milk, that can lead to the milk-alkali syndrome. Years ago, patients used to take this for dyspepsia. They would consume lots of calcium carbonate, which is Tums, and they would drink lots of milk. So why does consumption of exogenous alkali and calcium lead to the milk-alkali syndrome? Well, first of all, if you take in too much calcium, this leads to hypercalcemia, and then hypercalcemia due to any cause interferes with kidney function. Basically, hypercalcemia causes a vigorous diuresis. It inhibits the sodium-potassium 2-chloride pump in the thick ascending limb. This is the same channel that loop diuretics block, so hypercalcemia is like taking a loop diuretic. In addition, hypercalcemia blocks ADH-dependent water reabsorption in the collecting duct. So for both of these reasons, a vigorous diuresis occurs when patients take in too much calcium. This leads to volume contraction. So now you've got a situation where you've got a contraction alkalosis plus the patient is ingesting alkali. This leads to a metabolic alkalosis. In addition, the GFR falls from volume contraction. That leads to the renal failure with a high BUN and creatinine. So the triad of the milk-alkali syndrome is hypercalcemia, as shown here, plus a metabolic alkalosis, plus renal failure for these reasons right here. Moving on, let's talk about Bartter and Gittleman syndrome. These are both congenital disorders of the nephron that occur in children. And in both disorders, there's impaired sodium reabsorption in the nephron. So anytime you don't absorb sodium normally, you are going to get the same clinical effects as being on a diuretic, because that's what diuretics do. They block sodium resorption. So children with these disorders have polyuria. They can develop hypokalemia, just like patients on other diuretics can, and this sometimes leads to muscle cramps as a presenting complaint. And because they lose volume, they develop a metabolic alkalosis from a contraction alkalosis. I'll talk about Bartter syndrome first. Bartter syndrome occurs when there is defective sodium resorption in the thick ascending limb, the portion of the nephron I'm circling with my pen here. This will lead to the same clinical features as administration of a loop diuretic, because loop diuretics also block sodium resorption in the thick ascending limb. This presents in childhood, and it presents with polyuria, polydipsia, or nocturia. Basically, these children urinate constantly. This may make them thirsty, and sometimes they wet the bed because of high urine volume at night. Volume depletion is going to activate the RAS and lead to a metabolic alkalosis, just like we talked before with contraction alkalosis. Because there's more sodium delivery to the distal nephron, whenever this happens, this leads to hypokalemia. I talk about why this happens in the video on diuretics. And then finally, when you don't absorb sodium normally in the thick ascending limb, you also don't absorb calcium normally from the urine. So children with Bartter syndrome have a high urinary calcium, and this is one of the distinguishing features that helps you know you're dealing with a case of Bartter syndrome and not something else. In contrast, Gittleman syndrome occurs when there's defective sodium resorption in the distal tubule. That's this section of the nephron here. This is going to lead to the same clinical effects as administration of a thiazide diuretic. Just like Bartter syndrome, it presents in childhood. It can present with polyuria or polydipsia or nocturia. The volume depletion will activate the RAS, leading to a metabolic alkalosis, and because there is more sodium being excreted in the urine, that will draw out more potassium, and again you will get hypokalemia. The key distinction between Gittleman syndrome and Bartter syndrome is the urinary calcium. Urinary calcium is low in children with Gittleman syndrome. That's because the distal tubule normally secretes calcium into the urine. That doesn't happen in Gittleman syndrome, and as a result, the urinary calcium gets low. Next, let's talk about Little syndrome. Little syndrome is also a genetic disorder of electrolyte channels in the nephron, but in Little syndrome, there's increased activity of a channel. The ENaC channel, which is the epithelial sodium channel, that is normally activated by aldosterone, becomes overactive due to a genetic mutation in Little syndrome. This presents in juveniles, and it's going to present the same way as hyperaldosteronism. This sodium channel is going to be more active. There's going to be more potassium excretion into the urine. There's also going to be more acid secretion into the urine. So these patients are going to present with hypertension, hypokalemia, and metabolic alkalosis. However, their aldosterone level is going to be very, very low because this is not an aldosterone-related problem. So it's going to present as a young patient with hypertension and hypokalemia. They will also have a metabolic alkalosis. Aldosterone levels will be low. And you can treat this with amiloride. Amiloride is a potassium-sparing diuretic that blocks the ENaC channel. So in children who have Little syndrome, they can take amiloride, and that will limit the features of Little syndrome. SAME is the syndrome of apparent mineralocorticoid excess, and it gets its name because people with this disorder appear to have too much mineralocorticoid effects, in other words, too much aldosterone, but they don't. This is similar to Little syndrome, however, it has a different mechanism. The reason that SAME occurs is because renal aldosterone receptors can bind cortisol. In fact, they bind cortisol even more than they bind aldosterone, but normally cortisol has no effect in the kidneys. The reason for that is because cortisol is converted into a substance called cortisone, which does not bind to mineralocorticoid receptors. The enzyme that does this is 11-beta-hydroxysteroid dehydrogenase. So children with SAME are deficient in this enzyme. As a result, cortisol persists in the nephron and it binds to aldosterone receptors and produces aldosterone effects. SAME is going to present in children and adolescents, and it has a similar clinical presentation to hyperaldosteronism, hypertension, hypokalemia, and metabolic alkalosis. And just like we talked about in Little syndrome, aldosterone levels will be low because there will be negative feedback on release of aldosterone from the adrenal glands. You can treat this in two ways. You can administer a potassium-sparing diuretic that blocks the effect of mineralocorticoids. So amiloride, as we talked about, blocks the ENaC channel, and this blunts the effects of mineralocorticoids. Spironolactone blocks mineralocorticoid receptors, but that's effective in this disorder because the problem is from overactivity of cortisol on those. You also can administer dexamethasone. So why does this work? This will provide negative feedback on the adrenal glands and cause them to decrease cortisol production, and this can lead to an improvement in the hypertension and hypokalemia of SAME. If you understand SAME, it's easy to understand what happens when patients eat too much licorice. Licorice contains glyceretinic acid, which is a steroid. It has a weak mineralocorticoid effect, but its major problem if you consume too much of it is that it inhibits the renal 11-beta-hydroxysteroid dehydrogenase enzymes. So people who eat lots and lots of licorice can develop the same clinical features as SAME. They can develop hypertension, hypokalemia, and metabolic alkalosis, and their plasma aldosterone level will be low. The way you treat this disorder is to tell them to stop eating licorice. So in terms of board questions about metabolic alkalosis, a key distinguishing factor is whether or not hypertension is present. If hypertension is not present and there's a metabolic alkalosis in a child, you want to think about Bartter and Gittleman syndrome, and remember that those present with polyuria and cramps from abnormal potassium. If there is hypertension present, then you want to know what the aldosterone level is. If the aldosterone level is high, then that patient has hyperaldosteronism and they have a problem with their adrenal glands. If the aldosterone level is low, then they have one of the last three disorders we talked about, Little syndrome, SAME, or consuming too much licorice. I'll finish by making two special points about metabolic alkalosis. The first one has to do with urinary chloride. You can measure the amount of urinary chloride in the workup of metabolic alkalosis. This isn't often done, but you should understand the physiology of this test so you can answer questions about it on step 1. The urinary chloride level is very low in patients who have a metabolic alkalosis from gastric acid loss. That's because gastric acid contains chloride, and therefore when patients lose lots of it, their chloride level gets low and their urinary chloride level gets low. So patients who are vomiting or have a metabolic alkalosis from nasogastric suction, they will have low urinary chloride. In other causes of metabolic alkalosis, the findings are variable. Right after a patient takes a diuretic, the urinary chloride goes up because you block sodium chloride reabsorption. However, as time goes by, the patient reaches a new steady state and they may no longer have high chloride. It's only high immediately after taking a diuretic. And really, in most other causes of metabolic alkalosis, the findings are variable, and that's why this isn't a very useful test. It's really only useful for making a diagnosis of GI acid loss, which is usually obvious from the history. Administering intravenous fluids that contain sodium chloride resolves many forms of metabolic alkalosis. IV fluids contain sodium chloride and water, and if you give them to patients who have a metabolic alkalosis from diuretics or from vomiting, their metabolic alkalosis will improve. These are called chloride-responsive forms of metabolic alkalosis. So like I said before, contraction of volume is associated with a lot of metabolic alkalosis problems. So if you administer fluid, it resolves many of those problems. There are, of course, some exceptions. If the patient has hyperaldosteronism, the metabolic alkalosis is not going to get better with fluids. Patients who have Bartter or Gittleman syndrome are not going to get better. And of course, patients with heart failure or cirrhosis, if they have an alkalosis, these patients retain volume because of their underlying heart or liver disorder, so intravenous fluids is not going to help. And the last point I want to make in this video is about the lungs. Hypoventilation is the normal respiratory compensation to a metabolic alkalosis. So in the setting of a metabolic alkalosis, whatever the cause, the respiratory rate is going to fall. This will raise the PCO2 and lower the pH. If you look at the Henderson-Hasselbalch equation on the bottom of the screen here, in a metabolic alkalosis, the bicarb level goes up. This raises the pH. As a response, the respiratory rate falls and there will be alveolar hypoventilation, and this will raise the PCO2 and this will bring the pH back towards normal. Make sure you remember this so you can answer questions about how ventilation and respiratory rate change in response to a metabolic alkalosis. And that concludes our video on metabolic alkalosis.